Hi, everyone. Welcome to the Modern Mind interview series where we talk to real people just like you who are doing their best to be their best, but usually with a lens of expertise on a topic that is particularly interesting for us in the mental fitness community. So today I have with me Jane Muir, who is an expert at Penn on a lot of topics that we care here about when it comes to mental fitness. And so with that, first off, Jane, I just want to say welcome to the show.
Thank you. Thanks for having me. I'm excited to be here.
Awesome. Well, it would be great to get just a really quick background on who you are and where your areas of research have landed.
Sure. So I'm an assistant professor at the University of Pennsylvania in the School of Nursing in the Center for Health Outcomes and Policy Research. So that means that I do professor things. So I teach classes, I primarily do research, and I also practice as a nurse. So I'm in the School of Nursing as a professor, and I am a registered nurse, and I'm also a family nurse practitioner. So I practice as a family nurse practitioner in primary care. On Mondays, we're recording this on a Monday, and today's my practice day. So after this, I'll be going to my practice gig. And I primarily spend my time studying the nursing workforce and the reasons why nurses enter and exit the profession. Nursing is a very rigorous profession to work in. Healthcare is a really challenging profession to work in. And so the work I do in our center, in the Center for Health Outcomes and Policy Research, focuses on what's driving nurses to experience stress, burnout, turnover, and what can we do in the organizations where they're employed to keep them in that work because the safety of our public depends on nurses. The safety of healthcare, the health of our communities largely depend on nurses because nurses are the largest healthcare professional group in the United States and globally.
Wow. And let's talk a little bit more about the nursing profession. So, COVID happens. There was a whole lot of articles saying, we don't have enough nurses. We don't have enough nurses. Is that true? And being the largest workforce, specifically within the healthcare profession, what is driving them to leave?
We expanded the nursing workforce more in the past 10 years than in the past 3 decades prior. So
Wow.
we have grown the nursing workforce. There are just over 3 million nurses in the United States. And we've had shortages of nurses in the US, meaning shortages in the supply of nurses. And we certainly have shortages in certain parts of the US. You always have, it's rare that you would have adequate number of any professional throughout all places in the United States. So often in rural communities, you will see shortages in certain periods of time of nurses. In terms of having enough per capita in the United States, we have a robust number of nurses in the US. We have a large number. The issue, the way that we tend to frame it on our teams is, and I would say I feel the same way with my work, is we have a shortage of nursing care, meaning we don't have a shortage of nurses. We have a shortage of nurses willing to work in the current conditions of hospitals, of organizations. And hospitals are the largest employer in healthcare settings, meaning, nurses, larger number of nurses are working in hospitals than in like a primary care practice, although they do work in primary care because hospitals are huge employers. And nowadays, compared to like the 1920s, individuals go to hospitals for their care instead of being sick at home and being cared for by a home health nurse, although we are now trying to make a movement back to some of those patterns for various reasons. But the issue that we're having is not that we need to expand the educational, it's not that we need to find pathways to get people into nursing because we need to grow that profession. It's that we need to keep nurses in their jobs. We need to retain them. We need to be better at motivating them or demonstrating to them that working in a hospital is a worthwhile endeavor for them. And so if we were to unpack what nursing is about, first of all, you tend to have individuals who at their core want to help people. And so that means they tend to be selfless, caring individuals who are willing to give a lot of themselves to help other people. That is at the core of being a nurse. I think in recent decades and in recent years, and certainly exacerbated during the pandemic, the work of a nurse is compounded by a lot of external forces, internal and external to the organization. So how the healthcare industry, what the healthcare industry prioritizes can influence the work of a frontline nurse. So healthcare is a business, just like any other industry in the United States. We are seeing that the the profit focused nature of nursing, of healthcare has an effect on nurses' intention to stay in their job. It causes a lot of stress and pressures, meaning it can put pressures on how fast they need to see patients. It can contribute to moral distress in terms of um, what the organization prioritizes. Perhaps the organization doesn't they will report to us in our surveys that nurses aren't prioritized. Nurses are more encouraged to prioritize getting the patient through the system, getting them through the hospital, than maybe sitting down with them and asking, do you have food at home for after you get discharged? Who's picking you up after this? Do you understand your discharge instructions? Can you read them? They're caring for a high number of patients at a time. And I want to go back to that. And they're also now increasingly, we're seeing workplace violence, meaning violence specifically from patients and their family members and
Wow.
visitors onto nurses, being spit on, punched, kicked, really threatening. It can be life threatening going to work in some places. I wanted to revisit staffing because the core of my work as a researcher is working with my team at Chopper to conduct large surveys of nurses. So we'll write these surveys based on on empirical, work, how we've done surveys historically, globally, in the US. And we will ask nurses all about their working conditions. What's it like to work there? Why would you want to leave? Why would you want to stay? And what we find is that the number one reason why nurses are dissatisfied with their work has to do with the workload and the staffing. And this relates to the profit-based part of healthcare that nurses report on, in that they feel like they're working in environments where their organization is staffing at the margin. So they're staffing really at the thinnest, at the shortest, level that they can. And why that's a problem is that whenever there's any volume fluctuations or changes in patient acuity, patients can decline during a shift. There can be environmental factors that cause patients to come in all at once during the day, like a rainstorm that causes a car accident or a snowstorm. And all of that can change how many patients and nurses caring for at a time. But even on a regular typical day, we see that nurses are reporting, I'm caring for too many patients at a time. I can't possibly manage this many people at a time. And when we ask them what would bring you back into healthcare, what would prevent you from leaving, they say mandate safe ratios in our hospitals, meaning establish standards that hospitals have to follow so that we can work in a safe workplace, and that they are required to hire enough nurses. Otherwise, this is too much for me to handle. I feel unsafe. This is not why I entered healthcare. So safety, feeling unsafe at work, be it staffing ratios, workplace violence, all of these factors that have to do with the work environment are affecting nurses' well-being, and it is driving them out of wanting to work in certain jobs. And so I go back and I'll finish with nursing care. It's not about not having enough numbers. It's about they're not interested in working in these organizations. They'll find a different type of healthcare job. They will go into a different industry, perhaps, because it's not worth it to them. So they're out there. We just can't retain them.
Fascinating. And I think so much of what you brought up is mirrored, honestly, in a lot of workplaces. But what's so unique, I think, about healthcare is there is a direct one-to-one correlation, I have to imagine, between the ability of nurses to feel good at work and the ability of patients to get the care that they need. And so my question to you, I mean, one is tactical, which is like, do you have a sense of what those ratios are meant to be? Or does anybody, or is there work being done on that? And then my next question to you, related to that, would be, have you met nurses today who feel good in their job? And if so, why do they show up to work every day?
These are great questions. So starting with the first one around ratios, the state of California is a very interesting example and a case study of implementing safe staffing standards in the US. So in 2004, they passed and implemented a legislation called House Bill 394 that required hospitals to staff enough nurses so that nurses cared for no more than 4 patients at a time on medical surgical units, no more than 5 patients at a time in emergency departments, and there were different standards per unit. So different states have proposed similar legislation since that time. But up until 2023, California was the only state to have implemented a type of safety standard around nurse staffing ratios. And then Oregon passed a similar legislation in 2023. So now we have 2 states that have successfully passed this implementation. And so typically the ratios are around the types of units because the patients that are going to these units are different. So you can't do a catch-all 1 to 2. Like in the ICU, it's 1 to 2 because those patients need to be closely monitored by one nurse at a time. And the patients are so complex and that a nurse can't take care of more than 2 at a time. So it varies by specialty. Typically in a hospital, the largest proportion of units are medical surgical units, meaning like in a hospital, most of the units are these generalist units. And so on those units, the recommended ratio in most legislation is 1 to 4, and that's what got passed in California. And on this topic of California, if we want to talk about nurses that love their work environment, it's the California nurses. So we have studied the California nurses since 2006 because we did surveys of nurses since 1999. So in 2004, the legislation passed. In 2006, we asked nurses about their burnout, their intent to leave, and their job satisfaction, and we compared that to nurses that were working in non-California hospitals. Then we did the same analysis using 2016 data. And at both of those time points, we found that nurses in California compared to the non-California nurses had lower rates of burnout, job dissatisfaction, intent to leave.
Wow.
When we modeled the relationship between whether or not you're a California nurse and burnout, we found that it was the better staffing that was attributing their lower burnout. So the California nurses had lower odds of burnout compared to non-California nurses, and it was attributed to the better staffing in the California hospitals. So we can empirically point to, and we've done this longitudinally, right? So now we have 2 time points where we've demonstrated this evidence that this legislation around safety can confer better outcomes for the nurses. If it's conferring better outcomes for the nurses, one would think we're retaining nurses. The hospital doesn't need to spend money on continuing to recruit and retain, and hire these nurses and pay for onboarding and pay for incentives. So this is certainly something that is appealing to hospitals, and other states have caught on to this and wanted to pass such legislation. That's what happened in Oregon. So California has been a success story. And when we survey nurses and ask them to write to us and tell us with words instead of filling out multiple choice questions how they're feeling, we have nurses who will say, I worked as a travel nurse in California, and I became a permanent nurse once I went there because the benefits working there, the safety, not feeling like your license is on the line every day is a huge benefit of being there. They have more standards. They have better safety standards. And I think those who are resistant to that type of legislation think, well, this would be too expensive for our hospitals if we
That was going to be my next question.
If we set these standards. We've also studied that question, and we've found that the cost of reducing avoidable deaths, of avoided hospital days for patients can offset that cost of hiring enough nurses. So we have a cost effectiveness argument here. When you invest in having enough nurses, you're investing in safety. You're investing in more surveillance of patients. Doesn't everyone want their, imagine your family member is admitted to the hospital. How would you feel if I told you your nurse is caring for 9 patients right now? And so you'd be lucky if they come into the room every 4 hours, once every 4 hours.
Crazy.
We're trained as a nurse to go in the room at least once an hour, hopefully every 30 minutes. Like the way we're trained as nurses is do an assessment on your patient once an hour, take vitals every 30 minutes to an hour. If you are able to do that, you know that patient in and out, you know when they're deteriorating, you walk in the room, you have that intuition, you can tell like something's up. You can look at your vital signs, you can synthesize all the evidence provided to you and know how to take care of your loved one if they're declining or if they need something. Instead, in some hospitals where nurses are caring for 6, 7, 8, 9 patients at a time, patients are on the call bell. They're on the call bell needing to go to the bathroom by themselves, needing to get up, they need help. These are the consequences. And all of these things have downstream consequences: pressure ulcers, longer hospital stays, infections that you get in the hospital that weren't there before you came into it, surgical site wounds that don't heal properly because patients aren't getting the nutrition that they need or the cleaning of wounds. And this isn't an issue of, oh, the nurse is not educated enough. This is a systems issue of the nurse is not working in a system that safely sets them and the patient up for success. It's not just about, it's really not about the nurse being okay. It's about the nurse, it's first about the nurse wanting to provide safe care. If nurses are in this for their patients and they leave because of the patients, because they say, I can't do this anymore. I can't walk. It's moral distress. I can't walk in here and in good conscience watch these patients suffer because of the unsafe working conditions. And so it's an interesting overlap of the Venn diagram of like well-being of the nurse and the patient experience, which is what you asked about. And there's 20 years of evidence showing that nurse burnout is associated with worse patient outcomes. When more nurses in hospitals are burned out, the patient outcomes for that hospital are really bad. Higher odds of mortality in the hospital, 30-day mortality outside of the hospital, longer hospital stays. Yeah.
Absolutely. And by the way, there's so much here, Jane. The work that you do is incredibly important. I mean, being able to tell this story with data is everything, right? Because we've talked about this before offline. It's if you can't speak in the language of business, which is numbers and money, it's really hard to make sure that people are making the right decisions. And I'm curious, like, what do you think is the biggest barrier right now for hospitals, healthcare services firms to actually taking action on these studies? Is it really just a barrier in information and them not knowing? Or do you think that folks know and they're tired? Do they not have the skill set to actually make these shifts? What do you think it is?
I think two things. I think one is I don't think that researchers yet have mastered how to articulate the cost effectiveness bottom line argument, because I don't think we understand exactly like the spreadsheets and the financial lingo that healthcare administrators care about. And part of that is due to the complicated financial payment structure in the US around healthcare, meaning you can argue that you can put a price on a length of stay, but that depends on like the insurance reimbursement for these patients. That's assuming everyone's insurance reimbursement is the same for a hospital day. And so as researchers, we're doing the best that we can with the resources at our disposal, which is like Medicare data. So you're analyzing data from an older population where you have a defined like number on length of stay hospital days, but then that's a limitation because we can only say that's for patients over 65 years of age. And that's an important contribution to the literature. But hospitals are comprised of patients with a whole bunch of payer mix. Like they don't have insurance, they do have insurance. They have private, they have Medicaid, they have Medicare. So, and then there's the question, and so I think we have not yet, as researchers, articulated what are the numbers that matter. We think we've gone in that direction, but I don't think we've articulated really well yet what the cost effectiveness argument is around hiring enough nurses. The second thing I worry about that's a barrier is the culture around, the culture around nurses speaking up about their working conditions. I think sometimes we generally get clumped into this category of people who are complaining a lot. Like, nurses have been complaining for 20 years about this, to which I would say, right, because it has continued not to be addressed for 20 years. 20 years. We've talked about this a lot, this idea of like, I'm sick of talking about it too. I'd love to move on to another topic, right?
Yeah.
I'm sick of talking about how short staffing is the issue that drive nurses out of hospitals. And so there's a bit of like, is it doing the same thing over and over again? Is the definition of insanity? Or is it like, I think we get one thing that deters our argument is sort of this, we get stigmatized as like nurses are always complaining about their work environments and they're always complaining about the staffing, and it's really annoying. I do think my sense from healthcare leadership is, you know, it's never enough. You're always complaining about the staffing. But I just point people back to the evidence, and the evidence continues to show that, you know, over 50% of nurses are saying that their hospital is understaffed. You have to believe them. And these are nurses. They're the most trusted healthcare professionals in the US. So I think it's both. We need to refine and hone in on our language to speak the administrator language and the corporate language, because we're scientists. And healthcare professionals, and within the healthcare professional, we're sort of the most selfless, even in that hierarchy. And so that doesn't always come natural to us to go, okay, like what's the MBA framework for this? And so that's why it's been wonderful meeting you, and being on this podcast is great. On the other hand, I think there's still just like a lot of stigma around like nurses, and it's a gendered profession, and okay, you're always complaining about this issue. It's always the staffing. And I also think when you're thinking about an organization and a business, everyone knows that labor is mostly the largest cost for a business, just generally. And you sort of get this like, right, like, of course, you know, of course you're wanting to increase the labor. Well, that's my biggest line item on my budget. And that's just that's an uphill battle.
For sure. And I think it's interesting because there's a couple things you touched on there that are just like so relevant to workplaces in general, which are just that right now it's really difficult for administrators and staff to speak to each other in a way that each other understands. And I think, you know, this is literally why I do what I do, which is like helping to be that translator. And if folks are listening and working in an environment where they're saying, yeah, this is like me and my job too, the real question is like, how do you work to turn what you're doing into numbers and dollars? Because as somebody who does research on this within services businesses outside of healthcare, in addition to in the space, I've seen the same thing, which is that it's always a struggle to talk about these costs because they're costs that don't sit naturally on the balance sheet. When you talk about, I noticed one of the things you didn't talk about within your surveys was the cost of turnover, which, you know, I laugh, you put it, you know, your turnover numbers into one of these calculators online. They're like, you're losing $1 billion no matter how big your company is in hidden costs. The numbers are almost so astronomical that you can't really believe them. And therefore people don't think that much about them. I think to your point, and the second piece here, which is around communication, around how people feel within the workplace and really with the ability to be heard or not, I find that most of these feedback loops are missing. And to your point, even when they are there, there's enough emotion behind them that oftentimes it can be almost like viewed as hysterical, which obviously is partially gendered and partially a bunch of tired people not listening to each other. So that's all very real.
Right.
I'm curious, and obviously I can speak to this from my experience, but what have you seen works, if at all? Have you seen, I know obviously in California, we've talked about that state as a case study and their staffing ratios being pretty special. Have you seen anywhere outside of California and these staffing ratios? Have you seen them doing anything that is helpful?
I think I'll start with the feedback loop that you're referring to is really important and something that needs to change in this space. We surveyed my colleague Karen Lassiter and I, she's also a nursing professor. We did a study that was published in JAMA Network Open about New York and Illinois nurses working in New York and Illinois during COVID-19, so 2021 and 2021. And we asked them the top reasons why they left healthcare. And then we're doing this analysis again in 2025, hello. And one item has like moved up the list. It's gone up higher than it was. It's now number 2, and I think it was number 5 the first time we did the analysis. So staffing is always the first one. Unsafe staffing is the top reason why nurses leave healthcare. The one that has moved is my management does not feel valued by my employer. Did not feel valued by my employer is now number 2, and that was number 5. And even doing other separate analyses for different projects, I hear consistently what you've described, like the feedback loop is broken. Nurses don't feel like their concerns are heard by those who are representing them, meaning their unit management or their hospital management. So we're talking C-suites, chief nursing officer, if their hospital has one, chief executive officer, patient quality safety officer. And we're talking about, I'll say there is a stereotype about nurses that is true in all the TV shows like Nurse Jackie and ER and, The Pit. And it's that nurses are really intense about providing their thoughts on what, like, this is the issue and I know how this needs to be changed. Nurses are your best engineers on the front line. They're incredibly innovative. They're incredibly creative. They're operational engineers in terms of patient throughput and finding solutions to issues in the moment. And my concern is that nurses more than ever are saying that I'm not heard by my management. And I'm sick of shouting into a void about something that's compromising the safety of patients, and so I'm leaving. So this can be something like how unsafe it is that patients are in hallway beds in emergency departments and inpatient hospital settings, that it's a risk for patients to fall, or that they're getting up when they, a patient with a behavioral health issue who gets up out of the bed, but they're placed in a hallway and they should be in a private room. Or another example of behavioral health, the nurses are not safely set up in that unit, so they could get trapped easily with a patient who's violent potentially, who's exhibiting violence, for example. And a nurse can come up with 5 solutions to this issue, and they bring it to their management, and then they'll never get an email response, never an email follow-up, not invited into a meeting that's discussing this issue, the safety issue. Or maybe there's a standard in their hospital to write an adverse event report, and no one follows up with them when there's officers or individuals with that position whose job is to do that. So these are just examples I'm providing of what our nurses say in terms of what they mean by not feeling valued by their employer. You don't value my lived experience on the front line. I see this every day. I'm in harm's way because of it. I want to help this organization be more safe. My management could care less. So that's pretty shocking to me. And I think nurses feel like we are the ones on the front line providing the majority of direct patient care. We could make this a safer place and everyone's job easier, but we're not included in these conversations for whatever reason. So that is one point I would say in terms of what could make things work better. I provided a few examples. Having structure within hospitals where nurses can be represented, like in workplace violence working groups. So in hospitals, there are working groups and committees that are comprised of the C-suite and the leadership executives. And it's really important to make sure that there's a nurse represented. In my own career in academia, this is an example of something that nurses keep saying that people are sick of hearing us say. And I'm like, well, it's still happening. even in my own career, there's research that's being done on nurses and there's not one nurse on the author line. The corollary to that in a hospital setting is we're talking about a safety issue, workplace violence, and how to make settings safer. And there's not one nurse at the table, not one frontline nurse at the table. So that's a very important and pretty straightforward thing to modify, is looking around in the settings where you are and making sure that there is a diverse representation of the professionals who are experiencing this or reporting on it. A second thing that does seem to work, transparent reporting. Transparent reporting, what I mean by that is there are ways for employers, hospitals, healthcare organizations to be transparent both to the public and to nurses about the working conditions of hospitals. One example is the Centers for Medicare and Medicaid have this website called Care Compare, and you can go on that website and you can click 2 different hospitals and compare all their safety stats, like the fall rate, the pressure ulcer rate, There is no measure on the general CMS Compare website about nursing, like how's the staffing ratio or the turnover rate. There is one on CMS for nursing homes, because nursing homes have a really significant issue with there being fewer, like a huge patient to nurse staffing ratio. Like a whole nursing home is staffed by 1 or 2 nurses. That's crazy. And so a lot of evidence and families have pushed for there to be transparent reporting of what's the average patient to nurse staffing ratio in this nursing home, so that the public can make an informed decision about where they send their loved one for long-term care. We need to be doing that on the general CMS Compare website. We need to be doing that for hospitals, which would be the general Compare website, Care Compare. That would provide a lot of transparency to the public, and I think it would hold hospitals accountable in part to staff safely. Why? Well, we care a lot about patient experience. Why do we care about patient experience, also known as patient satisfaction ratings, or the HCAP score, hospital score? I don't know the exact terminology, the exact acronym. Well, that's because it's transparently reported. It's a required federal report. It's required to be reported on CMS Compare for any hospital that's getting money from the government for reimbursement, Medicare, CMS money. So what I'm saying is hospitals rise to the occasion when things are being transparently reported, like patient satisfaction ratings, because a patient can go onto their website and the patient is the consumer here. If we're talking about hospitals as a corporate framework, patients can go on the website and see on average what are people saying about this website, and they can choose to go to hospital B after reading about hospital A. The safe nurse staffing of a hospital is an important component of that equation. And so I think that would tremendously help and both inform the public and help us hold hospitals accountable on a policy level to safely staff. Another approach that I think has been effective are some of these systems, frameworks that incorporate some of this like feedback loop, some of these like, I don't want to say soft skills because I'm in this industry and I don't want to like soft skills myself, but some of these intangible things like feeling valued by your employer. Like part of the reason I think that they still persist is that they're difficult to measure. Yeah. And they involve some really intensive like leadership training and commitment to setting aside your ego, setting aside priorities, setting aside your own personal priorities to understand the priorities of the team, having high emotional intelligence. It requires a lot of these things. But there's a blueprint that's been established in the US called the Magnet Pathway Program. And the Magnet Pathway Program is basically this blueprint for investing in nursing. So Magnet is a designation that hospitals in the US can get if they invest in this program, where they have leadership training of their nurse leaders, training of their nurse managers. They commit to doing quality improvement and research projects at their hospital. They demonstrate a commitment and outcomes in terms of safer staffing ratios, cultivating a healthy work environment, being inclusive, having certain patient safety standards in place. And it's established by the American Nurse Credentialing Center. That's an organization in the US. And it's sort of a guideline that hospitals can invest in. It's an investment, a financial investment to become a magnet hospital. You have to demonstrate over a certain period of time how you are advancing these certain core measures of these, what would formerly be considered like less tangible things, more or less across the spectrum, I guess. And the data shows that when hospitals have magnet designation, they perform better on patient outcomes. The nurse retention is higher in these hospitals. The nurse burnout is lower. So
Wow.
although we're talking about a lot of these less quantitative, less objective measures of feeling valued by your employer and management and feedback loops, there are blueprints established in the US by nursing credentialing centers to cultivate that. I think not the issue, but sometimes these can be resource based. Like your success with these programs could be
Yeah.
correlated with having enough resources to invest in these programs. So there's always this continuous concern with like, how do we cultivate the best environments when you have resource constraints? And I think a lot of hospitals would argue we are all resource constrained, and so that's why we can't staff nurses appropriately, but
Yeah.
we know that that's not the case. We just did a study that was published in Medical Care that showed that for-profit compared to not-for-profit hospitals had less investment in nursing services than not-for-profit. So for-profits, compared to not-for-profits, these hospitals have different financial or potential missions. They could have different financial priorities and mission statements. For-profit institutions had higher patient to nurse staffing ratios, meaning the ratios were less safe. The work environment was rated less favorably than the not-for-profits. So there's a lot of emerging evidence in this area around, is it because hospitals don't have enough money that they aren't investing enough
Yeah.
nursing? And our research so far pushes back against that. And we also looked at operating margin, and we showed that there were no differences in the operating margins between these for-profit and not-for-profit. So it's not like one of these had more money than the other that was causing them not to invest. I think it's showing more of a mission statement commitment to this issue and understand. I think it takes a lot of bravery and courage for hospitals to understand, if you invest in enough nurses, your patient outcomes will follow, because this is the largest group of people who are overseeing and directly responsible for the outcomes of your patients. You
Yeah.
don't, one more thing I'll say is patients come to a hospital to be surveilled by a nurse. They don't come, the unique services and specialty services they're getting is like one small chunk of that experience. The remainder is being cared for and surveilled by a nurse. So knowing that, I mean, it's like having a fitness studio. Like I think about the spin model, the spin cycling, stationary bike, Soul Cycle, and the other ones. Those companies really got on the map because they invested in their instructors. Like they realized it's not our bike, it's the building and the bikes and the whole experience. Can you still hear me?
Yeah.
But it's largely the like investment in our instructors and their personalities and their enthusiasm and their commitment to our clientele. Not a direct comparison because it's a different type of industry, but I wish that hospitals, like employers, would understand your investment in your nurse is directly correlated with it is associated with your outcome, of your patient outcome, your consumer.
Absolutely. And again, this goes back to we've talked about it, but Zainab Tan's work on like a job strategy, just this idea that most of her work is actually focused in retail, but it's this idea, if you create great jobs for people, you just get greater output. Everyone loves Trader Joe's and we wonder why. And so much of that has to do with the operational choices they make to invest in their staff, which in so many ways are the steward of the entire business. especially the folks on the front line. And so I love that you use that example because I actually think it is a one-to-one. You invest in your talent, which again, to your point, majority of the talent on the field at any given time are your nurses, and everything else just goes better. So super interesting, Jane. You're totally brilliant. I feel like there's a million studies you referenced. I'm actually going to make sure we put them in the show notes so that people can check out your work. Because it is important that people are reading. I've been spending a lot more time in healthcare lately, and a lot of administrators are trying. And that's the interesting thing for me, which is like, when I asked you to be on the show, not only do I love chatting with you, but I do think that there's a real need to get the information out that you're sharing, because I don't think that people necessarily know. So there's the bad actors, but I'd argue a lot more of them are frazzle dazzled themselves. And so hopefully they can, take a look at some of this stuff. I want to turn the conversation, by the way, I could ask you a million more questions about your research, but I actually want to talk about you. I have this slew of questions just to get to know you a little bit better as an expert in the field, and you also as a nursing expert and professional. So my first question to you is, what led you to this field in the first place?
I was an undergraduate at the University of Virginia, and I was taking a Buddhism class as one of my religious studies requirements, or you have certain core requirements. And we were learning about meditation during this class, and there was a whole part of the class about PTSD among Vietnam War veterans and healthcare providers, and the role of meditation in mitigating the adverse effects of being exposed to trauma. And then that was in my first year of college. And then I was a Spanish language major, and then I decided I wanted to become a nurse. So I also got a degree in nursing in Spanish language. So I had to transfer into the nursing school, and we had to take an elective, and I signed up for mindfulness and compassion. I thought that was the course's name, and I thought it was going to be a pretty laid back, chill class where we were like sleeping, but it was pretty life changing for me. It was pretty transformational, because I think it taught me a lot of life skills that have helped me today with managing self-regulation and understanding your emotions, understanding your thoughts, and having how to relate to other people and be with other people, and what community means. It was led by Dr. Susan Bauer-Wu, who is a professor of nursing, and she ended up being the president of the Mind and Life Institute, which is a contemplative studies research institute. And what I mean by contemplative studies is people like Amishi Jha, who is from the University of Miami and study the effects of mindfulness on the brain. So these are like neuroscientists who study how these practices affect the brain and psychology. So it's psychologists, it's all these researchers from other fields. Susan was a nurse who is in this field, Dr. Susan Bauer-Wu. She became my mentor after I took this class. She introduced me to the work of Linda Aiken, of whom I work for now at Penn. And Linda Aiken is a pioneer of nursing. She established the evidence around unsafe nurse staffing ratios and unfavorable patient outcomes and nurse burnout. So in this class, we're learning about meditation, we're learning all these practices, but we're also synthesizing it with literature about the stress that nurses experience in their workplace. And so that was kind of the first time that I pieced together, wow, I'm about to enter a career that's incredibly stressful. Like, imagine you're a student. I mean, I guess the same could be said of like business school people who go on to Wall Street. It's like all you hear is like, it's going to suck. And so I think at that time I was like, man, I guess I should listen to these people who are saying that we need to be well equipped before we go into this job, because I'm hearing that it's going to be very stressful. And I'm reading all this research about how burnout is not only bad for you, but it's bad. It's like if people in business school were told, so you're going to be stressed on Wall Street or whatever job you're doing. And it's going to affect your bottom line, and it's going to affect your consumer too. And you'd be like, wait, but it's okay if it stresses me out, but I don't want it to affect like my performance. That would suck, because I need to like do well in my job. And so that's what I was piecing together, was like, whoa, this is not good for the nurse. And it's also killing patients that the nurses are burned out. I just
Totally.
had never thought of that like that. And I was like 20 at the time. So I embarked, as an undergraduate, I continued in this space, and I did a lot in the mindfulness meditation, contemplative sciences area, because the University of Virginia was leading an initiative and still is a leader in this space of contemplative studies, meaning that they were training students in the self-regulation and the meditation and the mindfulness for the rest of your life, like when you're about to go embark on your career. So the idea of preparing students for the future through contemplative studies. And so our nursing school had simulation labs and clinics and classrooms, and there were meditation spaces where you could go in at any time and get a cushion and get a yoga mat and get and do some drop-in classes in the middle of the day. And it was amazing. It was just state
Amazing.
of the art, and they're still doing great work there. I was just there for my reunion. So after that, I worked as a nurse and was like, oh yes, this was all real. This is all real that I read about in this class. This seems unsustainable. You become a nurse, you meet all these incredible people who've been in the job and are
Yeah.
very intelligent, hardworking. They're like your superheroes, and then they leave. And you're like, why are you leaving? And they're like, I can't work under these conditions. I feel disrespected working here. I don't get paid. You can't pay me enough to stay in this toxic work environment. And when you're a new nurse, it's just devastating. And like, also, what message does that send you very early on? It's that the good people are not, the people who you really respect can't hang. So like, how am I gonna hang here? Like, it's a very overwhelming
Totally.
experience. But I really leaned into applying the things that I had learned in undergrad into my work. I was an emergency department nurse. I still consider myself an emergency department nurse. I practiced for 7 years. And I was all about, like, can we bring meditation into this space and mindfulness? And so my my colleagues and I, we led initiatives where we would do, like, in the trauma bay, when patients were not there, we would do in drop-in meditations. Then I also helped. Well, I did a study,
Was
did
that
several
helpful to
studies.
people?
Oh, they loved it. It was it was just nice to have a grounding practice for your day, because when you're a nurse, you wake up, you've worked the shift before, you wake up and you feel so exhausted, you're going to do it again. You go to work, your priority is like caffeine and listen to the report about your patients, you get them all settled, and you are just like hitting the ground. There's no like easing into a healthcare job. There is actually a practice called the pause that one of my mentors, John Bartels, mentored me around with, and that's how we integrated it here. Was like, when the team has experienced a chaotic event, like a patient death or something just emotionally intense or difficult, like, we all need to congregate and do a 2-minute huddle and pause in silence and honor our work and honor the patients and our colleagues. And so I think just having a pause in your day is remarkably unheard of in some healthcare settings, because you're encouraged to just be on the hamster wheel. You don't sit, you don't get to pee. That is so real. Not getting a break. There are months of your job as a hospital nurse where you don't get a break. And then maybe the
Yeah.
seasons change and the patient volume slows down and you do get a break. So it's a lot. Also worked doing meditation retreats and mindfulness-based stress reduction interventions outside of work. So after work, there were nurses who enrolled in this study where they wanted to do like an MBSR thing after work, where we did sessions around what is meditation, what is a breathing, what is a body scan, what is a compassion, loving kindness meditation. Sharon Salzberg, or Sharon Salzberg. And then we would encourage them to do a meditation every day and record that. And so we did several interventions over a few years. And then I ran into a sort of passion shift. I was still very passionate about mindfulness, but I was more passionate about addressing these systemic and policy issues. I had a lot of enthusiasm to keep doing mindfulness. I was getting paid, people in leadership positions wanted me to keep doing that. But I knew that that wasn't what nurses wanted or needed because they told me, and I was living it myself. What they needed was more people on the floor to help give them breaks and to help surveil patients and take care of patients. But you can't like meditate yourself out of that. Like you can
Totally.
meditate to cope with that situation, but you need the meditation, but you also need these systemic supports for safety.
Totally.
So
I was
that's
going to
when
say you do need both.
you need both. I sincerely
Yeah,
think you need both. It's not a one or the other. And some people
totally.
hate the word resiliency, and I would say we need that. We need the resiliency of individuals because we can have the
Yeah,
best systems, but if we don't have resilient humans, having a good supportive system doesn't mean you're going to have every day is going to be like rainbows and butterflies. You're going to have horrible, unpredictable, horrific days at work. It just is going to happen. And so then I shifted into where I am now, which is being a health services researcher, studying more of these systemic issues, and I still integrate my work into that as well. But it eventually led me to get my PhD and then do a postdoc at Penn, and now I'm a professor at Penn. So
wow. Wow, wow, wow. Well, Jane, I'm so blown away, like I said, by your research, your expertise, and also the clarity of the issue. Like I said, very much relate to so much of what you shared because I see this as being the biggest driver of most business workplaces today as well, which is not like completely unmanaged workload against an understaffed workforce that doesn't feel appreciated or recognized for the work that they're doing. And again, appreciated and recognized means appreciated for the ideas that they bring to the table. And what I find, by the way, as a side note, is that most administrators believe that that means pay. And by the way, I always say pay is a hygiene metric. People scream about it when nothing else is working. And there was like real data around whether or not, obviously, nurses and the folks that I work with are getting paid the right amount. But that's just something, yeah, that I want to call out because it's something that I see a lot at a lot of different companies.
yeah, I know we're wrapping up, but I'll just say to
Yeah.
concur with you, you can't outpay a bad work environment in healthcare for nurses. There's many studies that have shown that.
Yeah, totally. Okay, so in one sentence each, what advice do you have for employers? What advice do you have for nurses who are employers who are trying to figure this out, nurses who are in stressful work environments?
My advice for employers is to listen to nurses and not just the ones in your institution, but those in diverse places like in academia and in industry jobs. Get more nurses on your team.
Love it.
They might be the secret to your operating margins or some operational metric that you want to improve. My top line advice for nurses is to elevate your voice, find places where your voice can be heard, be it in unions, through writing blogs, through joining your local specialty organization, because we need your voice now more than ever. The landscape of healthcare could change dramatically. The people trust nurses. People trust nurses, and you need to vocalize your concerns.
Love it. Amazing. Well, Jane, this has been so cool. I cannot get over how quickly time went.
I know.
I could spend like another 6 days with you. Thank you from the bottom of my heart for being here and sharing more of your work. Like I said, we're going to go ahead and share more of your information in the show notes. If people do want to learn more, whether it's a nurse or somebody who's an administrator of some sort of healthcare services firm, where is best for them to find you?
You can find me on LinkedIn is where I spend a lot of my time. I would just Google Jane Muir Penn, Jane Muir Penn, Penn. My last name is Muir, Muir. If you want to find me on X, it's at Jane Muir with 2 underscores. And I will provide other information for you for the description.
Perfect. All right, Jane, thank you so much for joining us today. And thank you everyone for joining us for another episode of The Modern Mind. Okay,